Hello, welcome everyone. Thanks for joining us today for the second installment of the Head and Neck Cancer Survivorship Symposium. As you know, we're hosting a webinar each Wednesday in August dedicated to different topics around head and neck cancer survivorship. This webinar today and all of these are hosted by the Ioneer Foundation of Pittsburgh in collaboration with the Department of Otolaryngology at the University of Pittsburgh. My name is Carrie Fogel. I'm the Director of Development and Foundation Relations at the Ioneer Foundation, and I'll be hosting today's webinar. Today's topic in survivorship is current standards and innovations in dysphagia management for head and neck cancer. And today's panel discussion will be moderated by Audrey Hayward.
Thank you, Carrie. We'd like to welcome Dr. Catherine Hutcheson. She is a professor in the Department of Head and Neck Surgery at the University of Texas MD Anderson Cancer Center. Dr. Hutcheson is a chief speech pathology and audiologist. She serves as director for research in the section of speech pathology and audiology. She's the director of the Voice Center and Audiology Fellowship Director and is a lecturer at the University of Houston. Dr. Hutcheson is a certified speech language pathologist with a doctorate degree in epidemiology. She has authored over 100 peer-reviewed and invited articles with funding support from the National Institutes of Health, the MD Anderson Institutional Research Grant Award Program, and a fellowship award from the Cancer Prevention Research Institute of Texas, University of Texas Health Initiative Training Program. She has co-authored or authored 12 book chapters. Dr. Hutcheson is a board certified specialist in swallowing and swallowing disorders. She is an accomplished clinician and educator who lectures nationally and internationally on radiation-associated dysphagia and head and neck cancer rehabilitation. The mission of her research is to optimize functional outcomes and quality of life in head and neck cancer survivorship. We are pleased to have Dr. Hutcheson, as well as colleagues Carly Barbon and Holly McMillan with us today. Please welcome Dr. Hutcheson.
Thank you so much, Audrey, and to our friends and colleagues at Pittsburgh for inviting us to join the Survivorship Symposium this year. So the lineup today is for me to start with a sort of introduction to current standards in dysphagia and head and neck cancer, and follow that with a discussion of some innovations in treatment protocols integrating biofeedback and novel protocols of manual therapy by my colleagues, Dr. Carly Barbon, who's a postdoctoral research fellow with us here and will be joining our faculty this fall, as well as Holly McMillan, who's a senior speech pathologist on our team, co-director of our Trismus Clinic and a PhD student with us. So with that, let's dig in to the content area. These are my disclosures. We know that dysphagia is common in head and neck cancer, and the exact prevalence of dysphagia really depends on how and when we measure it. Here, for instance, you see 2-year prevalence estimates of dysphagia using administrative or claims data in the SEER Medicare database, suggesting that on the whole, there's about a 60% 2-year prevalence of swallowing difficulty among head and neck cancer survivors. The prevalence is highest, as we would expect, in patients who've been treated with multiple modalities of treatment, highest among those receiving chemoradiation, next followed by patients receiving surgery and adjuvant radiation, but still very meaningful prevalence between 26 and 40% among patients treated with single modalities of care. And dysphagia in this population is quite complex. So there are diverse anatomic locations where the cancer arises. There are significant nuances to the delivery of particularly local and regional therapies, so variations in radiation technique, surgical methodology, such that dysphagia in the head and neck cancer population really takes multiple forms, and it can affect multiple phases of the swallowing mechanism. Outside of the disease, the patient themselves brings a number of factors that will influence this swallowing presentation. And I like to largely think about these as the key factors that are individual patient factors being those that really affect or adjust the functional reserve of the patient. And specifically in the setting of cancer treatment, the functional reserve representing sort of the ability of the patient to compensate for some of the unavoidable injury that will occur to the swallowing mechanism as a result of the tumor and its treatment. So key factors influencing the functional reserve include comorbidities that in and of themselves can have direct implication on swallowing function, but also age. And that's really related to the very well-established phenomenon of presbyphagia, whereby as we age, for instance, swallowing slows down in its process. But it also represents changes such as frailty and sarcopenia that increase in prevalence, again, with general aging. So here you see an example of a sort of classic severe baseline dysphagia that I would consider to be an obstructive or tumor-associated dysphagia in the setting of a very large locally advanced disease. You can see this prominent tumor in the posterior pharyngeal wall, T4 hypopharyngeal cancer. And this is clearly a presentation of severe baseline dysphagia. It's important to note that this type of presentation with quite severe dysfunction at baseline is actually the exception and not the rule, and should be expected predominantly in scenarios of very locally advanced T4 tumors, or every once in a while N3 disease that's causing significant compressive effect. What's far more common is for patients to actually enter their treatment with a functional baseline swallow or more of a mild dysphagia, such as the one that you see depicted here. And this is even in the setting of a fairly large T3 hypopharyngeal tumor that's sort of fixing the mobility of the ipsilateral larynx at baseline and sort of obstructing that lateral channel of the pharynx. Even in this setting, patients often will have a reasonable degree of swallowing function, and our goal with baseline examination here should be to identify how we can help the patient maintain the safest and most efficient swallow going into their treatment, so that we can really promote our key philosophy in dysphagia management of use it or lose it throughout the treatment interval. It's very commonly the effects not of the tumor and the disease itself, but more the treatment that ultimately drive the final swallowing outcome for the patient. And this is predominantly the local regional therapies. Here you see key factors driving the surgical effect on the swallow, predominantly being the site and the volume of the resection. When we think about the site of resection, it's very critical to think about the normal function of the structure that's being resected as it relates to swallowing. And that can help us to project forward really the expected type or nature of swallowing impairment. The volume of resection will really help to dictate the severity of that dysphagia, and that can be thought about by proxy at baseline based on the T stage of the patient. And then the other details that still have influence are things such as the surgical approach. Will it disrupt critical swallowing musculature as the surgeon is dissecting through to access the tumor for resection? And the closure, with the ideal closure being one that reconstitutes not just the form of the structure resected, but also the function or mobility. Now, there are a number of normal tissue changes with radiation that we know can significantly influence dysphagia. Those normal tissue changes underlying radiation-associated dysphagia occur along a continuum as a patient journeys through their survivorship. But there are factors that really predominate in each phase. So for instance, if I drop the scope in a patient who's experiencing dysphagia in the early weeks, months following their radiation, I expect to see at least a pretty predominant picture of edema, swelling in the laryngeal apparatus and the pharynx that's contributing to sensory change and also change in mobility of those structures for swallowing. As a patient journeys a bit further into their recovery, particularly the early few years of survivorship, that can also often evolve into a picture of subcutaneous or submucosal fibrosis, such as the one you see pictured in the middle here, really showing induration, hardening, stiffening of those structures, and almost a sort of a lack of definition between the normal structures. It's been classically thought that edema and fibrosis are the key factors that underlie sort of early classic forms of post-radiation dysphagia, that dysphagia that develops in the months following radiation and then just persists into long-term survivorship. We are increasingly recognizing the phenomenon of late onset of radiation-associated dysphagia that we often refer to as late RAD. And in this particular population, in patients who present many years into survivorship with new onset or new very pronounced progression of an underlying dysphagia, we recognize a strong element of denervation or actual nerve dysfunction that underlies some of the pathology in the swallow. So edema and fibrosis are quite common in the first years after head and neck cancer survivorship. We'll hear about this in Holly's presentation. These are now older data from Vanderbilt in a very high frequency longitudinal cohort study where they established that the prevalence of moderate to severe edema in the first 18 months of survivorship after head and neck radiotherapy hovered around 75% and peaked at about 10 months of survivorship. In this same cohort, they found that close to 50% of patients developed at least moderate, so grade 2 or higher cervical fibrosis. And again, this peaked a bit later in the trajectory, but just at about 13 months in its prevalence. Far less common, but associated with quite significant dysphagia is the development of lower cranial neuropathy as a late effect of radiotherapy, historically thought to be an issue primarily for patients with nasopharyngeal cancers, but emerging work now out of the last decade or so has really shown that this is a problem, particularly in long-term survivorship of oropharynx cancers. On the left, we see a recent cohort analysis in almost 2,000 patients from MD Anderson, suggesting that the lifetime prevalence of developing a cranial neuropathy as a late effect of treatment hovers around at least 10%. This is most commonly detected first in the 12th nerve, with a median latency between about 5 and 8 years. So regardless the pathology underlying the dysphagia, effective management really begins with a comprehensive evaluation. And the goal of that evaluation is clearly to identify the pathophysiology or the source of the dysphagia so that we can match the appropriate treatment to the individual patient presentation. With me, this really starts with trying to understand the symptom profile and a simple question of, are you experiencing swallowing difficulty with solids, with liquids, or both, is sort of the starting point for me to kind of think through the primary factors that might require management. If a patient's experiencing difficulty swallowing solids, we need to discriminate the pathology being one of poor propulsion, which could come from the tongue or the pharynx, versus an outlet obstruction, so a stricture in the cervical esophagus or pharynx, versus a problem with preparation on the bolus, which could of course be issues with mastication or salivary flow. And all of these factors might coexist, or we might identify a predominant factor to really target in our treatment planning. For a patient who describes difficulty swallowing liquids, I'm of course concerned predominantly with aspiration. But again, this might have various sources of pathology underlying the aspiration. So is the issue one of poor laryngeal closure, either timing of closure or integrity of closure? Or does it instead represent a problem of residual backflowing into the airway after the attempt at swallowing, which going back to the left-hand side could be related to both poor propulsion or stricture? Here you see the components of the comprehensive swallow evaluation that we use in our standard protocol at MD Anderson. We couple a physical examination with imaging for objective documentation of swallowing safety and efficiency. So how well are you clearing a bolus through the mouth and the pharynx, as well as an assessment of swallow physiology. Our primary go-to is the modified barium swallow study, but FEES is also an exceptional test in many populations. We couple this with a standard rating of what the patient is able to eat. So the performance status scale of head and neck cancer, specifically the normalcy of diet domain. And finally, how the patient perceives their swallowing abilities. And for this, we use the MD Anderson Dysphagia Inventory. This is by no means the only data that we bring to the table in our dysphagia management. There are a number of adjunctive measures, and just some of those are shown here that can add a lot of value and nuance to the diagnostic workup. These include laryngoscopy, standardized measures of lingual, jaw, cervical range of motion, measures of lingual strength, etc. Our actual therapy for dysphagia starts with prevention, the philosophy being use it or lose it through the treatment interval. The goal is to maintain maximum use of the swallowing mechanism through treatment to preserve its function. This can be done by swallowing exercise. It can also be done by promoting continued oral intake of both challenging and safe to eat consistencies throughout the treatment interval. This protocol is most established for patients receiving radiotherapy, and we know that in this population, there are a host of toxicities that really influence the eating experience. Mucositis, odynophagia, mucus accumulation can all make eating quite unpleasant in this journey, and it's well established that the vast majority of patients stop eating their normal diet during radiotherapy. And the premise behind proactive or preventive radiation swallowing therapy is to work against the phenomenon of disuse atrophy that occurs when a patient stops eating what they normally would. There is an abundant body of single institution studies to support potential benefit of performing swallowing exercise during radiotherapy, and just some of those are shown here. There's also single institution data to support the benefit of eating during radiotherapy. The diet level of an individual at the end of radiotherapy significantly predicts for their diet level at a full year later. And in old data out of MUSC, they've demonstrated that an MPO interval as short as 2 weeks during radiotherapy significantly influences swallowing related quality of life scores a full 5 years later. At Anderson, we've gone on and again, single institution observational data. These are now almost 10 years old, but to demonstrate both the feasibility of eating and exercising during radiotherapy shown here, and the association, the independent association of both eating and exercising with better outcomes. So for instance, here you see better diet level in patients who both ate and exercised during radiotherapy, more than 90% of this group eating a regular diet and long-term survivorship, compared to only 2/3 of patients achieving that ideal outcome if they were pharyngeal inactive during their radiotherapy. Same findings were shown with the duration of gastrostomy dependence during the radiation interval here. I have the pleasure of co-leading with my colleague Rosemary Martino now a large pragmatic multi-site study called Proactive that is seeking to understand the effectiveness of different models of proactive swallowing therapy and can be considered a prospective validation in part of these earlier retrospective findings. So despite our best efforts at prevention, at least a quarter of patients will go on to develop moderate to severe dysphagia, and there are a host of swallowing therapies that are available to try to target the individual pathology. I've tried to organize those on this slide here as those that target the mobility of swallowing structures versus those that target the strength or skill of the system. And a more intensive, but also a more personalized option is required, combining these types of therapies for patients who develop persistent, chronic, or late dysphagia after their head and neck cancer treatment. At Anderson, we have developed and optimized over the last 7 years or so a program that we call Boot Camp Swallowing Therapy that goes in a stepwise fashion to try to organize all of these options into a process that makes sense for the needs of a head and neck cancer patient who's who's experiencing persistent or late dysphagia. It starts with a comprehensive evaluation, a consensus or planning meeting, and then integrates first therapies that are designed to optimize the swallowing system, combining exercises, soft tissue mobilization, or other medical therapies first, and then implementing therapies that are targeting mass practice of more intense swallows in the functional phase of therapy. When we implement this model, it's extremely important to be mindful of the amount of time that it takes both for the patient and the clinician, and matching the actual therapy to the pathology of the dysphagia. So with that, I will wrap up and just conclude that dysphagia in the head and neck cancer population is common and complex. Not all head and neck cancer impacts swallowing function similarly. Standardized evaluation protocols and pathways offer us a framework to optimize care. We advocate for the use it or lose it philosophy and a proactive approach to management, and interdisciplinary intensive paradigms for persistent, chronic, or late dysphagia. I thank you for your time and welcome Dr. Carly Barbone to the webinar, to the panel next.
Okay, thank you, Dr. Hutcheson. I think you should all be able to see my screen. So I'm really excited to be here today to talk to you a little bit about post-surgical oral rehabilitation of speech and swallowing. I'm incorporating some biofeedback into that. Yeah, let's see, here's some disclosures of mine. And so what I'm going to be doing today is focusing specifically on partial to hemiglossectomy, where we have multiple drivers of dysfunction in this patient population. So drivers of functional mastication, swallowing, and speech. And so we generally assume in this patient population that these individuals have fairly good outcomes related to their speech and swallowing, but they do present with decreased intelligibility, impaired bolus manipulation, and dysphagia. And so there's a lot more that we can do for these individuals. And so the strategy and the techniques of the rehabilitation of the post-glossectomy patient are really directly related to a variety of important important details that really drive the post-operative function. And so those are the site of the cancer, the size of the surgical defect, and the details of the reconstruction. And so all of these then contribute to what we see when the patients present to us post-op in terms of the changes in speech, mastication, and swallowing. And so one focus is lingual mobility. And reduction in lingual mobility is really associated with poor speech and swallowing outcomes after partial glossectomy. And when we have patients come to us with adequate tongue mobility, we really notice that it's helpful, and it's really critical for bolus manipulation, bolus control, and propulsion into the pharynx when we have really nice lingual movement. And we have data from a speech pathology practice pattern survey in head and neck cancer, and the respondents, so 99.6 respondents routinely assess tongue range of motion. However, only 9% of those individuals actually measure tongue range of motion objectively. So, things like with a ruler or an objective measure. And so this tongue range of motion or range of movement measurement system was validated by correlating tongue range of motion along with various aspects of functional outcomes, so performance status and patient reported quality of life. And so this is a really nice start for us to track patient function from pre to post-op throughout the patient's journey. But we definitely need more additional validated outcomes for this patient population. We're really lacking in that space. And we do have evidence to support that the impairment in tongue function significantly impacts quality of life. And these data are out of Michigan, and they relate tongue mobility to quality of life and diet. And so the figure that you're looking at on the right here demonstrates that patients who are able to elevate their tongue greater than 1.5 centimeters and protrude their tongue greater than 0.8 centimeters had improved range of diet and also had improved quality of life. And so definitely impacts dysphagia in this population when we get that increased tongue range of motion. And so I think then that we can all agree that the key here is to optimize our function in our patients. We want full unrestricted mobility of tongue tip and blade. And the literature that we have is really right now based on a lot of cohort studies that are quite small without that objective hard speech and swallowing outcome data that we need. So these data come from our colleagues in Japan who conducted a non-randomized cohort study, and they looked at the risk factors of post-operative dysphagia. And this is in a cohort of previously untreated oral squame patients who underwent surgery. And they found that in patients with these three factors that you see here on the right, those factors were the highest related to a risk for post-operative dysphagia. And so these are contemporary perspective data where patients receive some therapy. A home program with some possible compensatory strategies. And you can see that they've monitored normalcy of diet on the PSSHN scale. And you can see an aggregate here in gray. The mean diet at baseline is quite reasonable. However, when we get to about 3 months' time, we're hovering around 60. And in that trajectory, we dip as low as 40, where patients are technically eating anything from dry breads and crackers to a more restricted diet, such as, soft textures or mashed textures. And although this timeline that you see here on the screen is still the subacute time point in the patient's post-operative journey, the diet levels don't really creep back to normal. And so we really do need longitudinal data to track patients' function over time in terms of their eating status. And so when we think about rehabilitation, we can group our functional targets into 3 bins, and that being speech, swallowing, and mastication. And so really, as Dr. Hutcheson mentioned, the degree and the precision of the tongue range of motion. So you want different things such as strength and control. We also, with glossectomy, post-glossectomy patients, want the tongue to be able to act like a finger, where we can get into the buccal cavity and scrape out any stasis that we may have. And so all of these tasks that you see require varying efforts of the tongue and require varying functions, tongue function. And so as the load that's required fluctuates, it makes the rehabilitation process quite multidimensional for us. And so we have, a clinical toolbox that's filled with, some of these tools that you see here on the screen. And swallowing really takes the heavy focus in the early stages with this patient population. And we can employ some of these strategies as we begin to advance diet. For example, they can help to facilitate mastication in the early post-operative stages to get patients starting to advance their diet. And so the tools that we end up using depend on the patient and their goals as well when they come to us. So the data really show that, as I mentioned before, head and neck patients who have undergone surgery or primary radiation, chemoradiation, demonstrate reduced lingual strength. But as I mentioned, when we have patients who have greater tongue strength, they present with improved speech and improved swallowing related quality of life. And so here we have a monitoring of tongue pressure across time in a post-operative cohort, all oral cavity surgical patients. And so if you look at the whole cohort in general, all of the tongue pressures from baseline to 3 months all fall below what we consider a healthy tongue pressure, which is 40 kilopascals. So they all fall below normal across the trajectory. The tongue patients who I've highlighted in red there, you can see their journey across the 3 months, are not only well below normal, but they're also below normative healthy swallow pressures. So, when we think about healthy individuals, they have substantial muscle reserve that isn't really used in swallowing. And since swallowing really is a submaximal task, it's important for us to focus on strength, and on skill. And so strength training alone can result in poor carryover when we think of the actual task that we're trying to achieve. But if we look at the data behind tongue strength, we know that it's helpful. But what happens when we pair tongue strengthening with skill-based rehabilitation in a therapeutic paradigm? So our colleagues who work in Parkinson's have created a program that's modeled on skill over strength, where patients undergo daily sessions of skill training therapy, about 10 days of therapy focused on increasing their precision in muscle contraction and targets using visual feedback, so a biofeedback type paradigm. So, it's not just about strength to hit a target, but it's also sometimes about how precise we are at getting to that target and the speed at which we can get to that target. And we also have data in the pharynx that show this. And so the study that you're looking at right now, it's led by Doug Chapea. He's a surgeon at the Princess Margaret Hospital in Toronto, where a piece of the puzzle in this study is focusing on fine motor movement. And so the primary goal is to really determine the benefit of a SLP-directed face-to-face rehabilitation program versus a self-directed tongue strengthening program. And then from there, determining whether there's any added benefit from a biofeedback paradigm. And so this population is really a population for whom there's a lot of need, but not necessarily a lot of protocols that have been established in terms of speech and swallow for them. And so what I want to highlight today are some of the lessons that I've learned in the therapy to date, where we can incorporate fine motor movement with tongue contact drills and purposeful strengthening. So strengthening towards a target that we're trying to achieve, to look at whether this paradigm perhaps might be useful for improving submaximal precision of tongue movement and of range of motion. And we're really hoping that therapeutically, this will translate to patient regaining that fine motor finger function of the tongue by enhancing the feedback of that placement that we're doing in the therapy with them. And so I'm going to kind of end with a case that is a young man from Toronto. He underwent a left partial glossectomy and neck dissection in April of 2020, and then went on to have post-operative radiation, completed that in July of 2020. And then he came to me about a year later. So I started seeing him in March of 2021. And he, again, 35 years old, he was working, active. He was using a feeding tube to supplement during his radiation. He actually said that really saved him. He was instructed to do exercise during, and so he also expressed compliance with that. I mean, minimal, but he said he was still trying to attempt any type of exercise he could. And so you can see here his baseline measures. Primarily, his area of concern was swallowing and mastication, but we also worked on his speech as well because he had some goals in that space. And he was the primary goal that we started off on was using the therapy to increase bilateral chewing. And so he was chewing and avoiding his defect side. And so that was, something that we worked on. And he had also, like you can see, a lot of coughing with liquids, food getting stuck. So he was up and down during meals to brush his teeth or to get rid of any residue that he had in his oral cavity. And so depending on the functional profile when we see patients and they enter the rehabilitation, the gains that we achieve differ as we shift the emphasis of the functional targets. And so although this patient had, swallow focused goals, like I said, we also worked on his speech. We also have patients who just come in for speech, and so it varies. So I have some speech samples from before he began any type of rehabilitation.
Teach a subject how to score higher on the tests that measure his imagination.
So that was one of his samples. And then I have another 15A.
Draw a design on paper and tape it to the opposite side of the glass.
Okay, and then this is his speech after.
Once this has been done, how do you change your motivation?
12A.
I hadn't even thought of the matter until a few miles back.
So he was a lot more precise in his articulation, but there were a few swallow specific, I think, wins that we ended up achieving. So number one was the elimination of his need for a water wash. I really think that this is such an important aspect of the rehabilitation process and also function. I think that after patients require less and less need for water wash, it really enables them to be able to not have to go to the restroom to, wash down or eliminate residue in their oral cavity. And so that's a really big win. Also, the ability to achieve tongue extension, so cleaning and clearance during a meal. So these types of functional outcomes really open up a world of dining for our patients. He was able to coordinate chewing, and he also less frequent cough while he was eating. He said that he was able to really pay attention less to his swallowing, but focus on what he really needed to during our therapy. And so again, small gains, but really made a huge difference in his function afterwards. And so, I think that, there we go. I think that the patients really have a lot of potential to optimize their function, and we really do owe them that opportunity to work on these things. Although they may seem small, they are certainly huge in terms of their function and their quality of life. And so this isn't without hard work and dedication from the patient. They really need to be all in. And I always tell them that we're starting with a different baseline, but we want to maximize whatever potential that we can get from them. And so I really love this quote. It speaks to how important the tongue is in our daily lives. And I will leave you with that. And I want to thank you for listening and thank my mentors.
Thank you very much, Carly. There we go. Holly McMillan, are you on and able to move forward?
Yes, we should be loaded. See my screen?
We do see your screen. Thank you very much for being on with us today.
Excellent. Thank you everyone for joining us today. And thank you, Drs. Hutcheson and Barbone. I'm excited to wrap us up today as we begin discussing the integration of manual therapy into dysphagia management for head and neck cancer survivors. I have no relevant disclosures, but patients have provided us with permission to use their images for teaching purposes, and I ask that you please refrain from taking screenshots or photos to protect and respect their privacy today. In long-term head and neck cancer survivors with late rad or post-operative dysphagia, muscles can demonstrate reduced capacity for contraction and appropriate range of motion due to radiation fibrosis syndrome or post-operative adhesions and scarring. And this can result in head drop position, lymphedema, trismus, and an array of other complications. So the bottom line is it's a problem and it impacts swallow function. Here we're looking at 1 to 2 year prevalence estimates for patients that have had multimodality oncology intervention. And as Dr. Hutcheson mentioned earlier, about 75% of patients go on to develop moderate to severe head and neck lymphedema. And this data is pulled from 2016 and 17, and even more recent data, the prevalence estimates reach 90%. About half of the patients go on to develop grade 2 or moderate fibrosis. 45% of patients are presenting with trismus, and almost 90% present with abnormal cervical posture, with 70% reporting neck disability and 35% of patients reporting shoulder pain. So when we look at these prevalence ranges, we're looking at a third to nearly all patients, meaning that the majority of these head and neck survivors are experiencing some degree of soft tissue toxicity. When we see lymphedema, fibrosis, musculoskeletal impairments, it can clinically manifest into functional deficits as a result of forward head posture, torticollis or head tilt, reduced cervical range of motion, respiration. So you can see this gentleman here presents with a stoma as well as head and neck lymphedema. So when he looks straight ahead, we become concerned about his airway and breathing as his lymphedema overhangs that stoma. We also appreciate internal oropharyngeal and laryngeal edema affecting respiration. Hypoglossal palsy can impair oral phase of swallowing, and that's manipulating the bolus, transferring it from the front to the back of the mouth, as well as anterior and posterior spillage into or out of the mouth. Internal head and neck lymphedema can also cause deficits in pharyngeal phase of swallowing, both affecting safety and efficiency. Muscle strain is very common and can also cause deficits in both communication and swallowing. Scar tethering as well. Here we can appreciate this patient with the neck dissection has deficits in cervical range of motion. And then this patient here with a free flap on the right side of the screen presented with deficits in both articulation, speech intelligibility, and oral phase of swallowing. Trismus can result in multiple safety concerns. These can be related to intubation, emesis, oral medications, and maintaining their nutritional status if they're eating by mouth. And pain can impact all domains of function. We use manual therapies to mitigate some of these soft tissue toxicities, and I love this definition by the AMPTA. It refers to manual therapy as hand movements that are intended to improve soft tissue pliability, range of motion, and relaxation. This is mobilizing or manipulating soft tissue and joints to decrease pain, swelling, inflammation, and restriction. So a really nice comprehensive definition. And whether it's the clinician providing the manual therapy and training the patient in manual therapy, or it's the patient performing self-MT at home to maintain and improve those clinical gains, the goal is always the same. It's to reduce muscle and fascial dysfunction to improve muscle movement and sensory feedback. Most often we see manual therapy used for respiratory support training or in the form of myofascial release, manual lymphatic drainage, massage, stretching, strengthening, and other modalities. And these modalities can include a wide variety of tools, cupping, vibration, pneumatic pumps, laser treatments, stretching devices, kinesio tape, and the list can really go on. But before we dive into treatment, it's important to note that manual therapies are tools in the toolbox, and they need to be used judiciously. These are not benign treatments that can be used across all patients at all times. Most commonly at Anderson, contraindications include dermal metastasis, acute infection. Most commonly we see cellulitis in the head and neck, areas of breakdown within the radiation or surgical fields, tumor burden, as well as local fistulas and unstable fractures. So we'll take a look at 3 case examples today. The first patient coming to us with fibrosis and lymphedema impacting cervical range of motion. This patient had a T4A, N2B, P16 positive squamous cell carcinoma of the right base of tongue. He underwent induction chemotherapy followed by concurrent treatment and then a left neck dissection. He had reduced cervical range of motion because of these toxicities of treatment. He was cleared by cardiology. We like to check in with cardiology whenever there's fibrosis in the lateral neck. His swallow study, 2.5 years after his treatment, revealed a severe dysphagia impacting both safety and efficiency with chronic sensate aspiration of liquids and significant residue with solids. He did present with a unilateral cranial nerve 10 paresis, and he had significant range of motion deficits in all 6 out of 6 planes of motion. His goals were to improve dysphagia, speech intelligibility, oral opening, and really important to the patient was reducing the discomfort associated with these toxicities. In this case, manual therapy was the primary treatment. And in just 12 weeks, we can see that cervical range of motion improved, not normalized, but improved. And we can really appreciate that change and extension, improving by 22 degrees. He also had a significant improvement in discomfort, moving from 14 out of 16 subsites with moderate discomfort to only 4 out of 6, so a major improvement. We also see modest gains in oral opening, safety scores improved on the swallow study, as well as MDAI scores, MD Anderson dysphagia inventory scores. This patient presented to us with trismus. So he presented with a T4N1 squamous cell carcinoma of the left oropharynx. He completed chemoradiation in 2010. His dysphagia was related to progressive late radiation toxicities. We did not have any safety concerns with his carotids. He did present with recurrent aspiration pneumonia, twice requiring hospitalization. So his modified barium swallow study 9 years after his initial treatment revealed a severe dysphagia, again, impairing both safety and efficiency, bilateral lower cranial neuropathy. The key here is the patient was unable to use the EMST device. He was unable to insert it into the oral cavity because of trismus. So our goal was to insert the EMST device into the oral cavity, ultimately to advance his diet. In this case, manual therapy was a primary treatment used as a frontline to optimize the patient for EMST use. The primary goal of manual therapy was quickly met, opening the patient's mouth from 19 to 27 millimeters, easily inserting that mouthpiece for EMST. And manual therapy has been shown to be effective for this indication. It's a quick, non-invasive tool for oral opening. We can see, again, he had no labial seal with EMST. That was able to be completed. And then the patient proceeded through with EMST. There was minimal change to his digest score, but he was no longer experiencing those aspiration pneumonias following EMST. So we saw him in total for 2 sessions over 2 months, and he had a great outcome with manual therapy. This third and final patient came to us with a salivary gland cancer over 20 years ago. He had a right neck dissection twice, a parotidectomy, and ipsilateral radiation in 1995. This patient presented with dysphagia because of gravity-assisted aspiration. He had an NPO status, feeding tube dependent, for the last year with a very severe decline in speech intelligibility. He was considering a total laryngectomy due to the long-standing profound dysphagia and recurrent aspiration pneumonias. Our goals were to avoid a laryngectomy, resume PO for pleasure, and improve speech intelligibility so that he could continue working. In this case, manual therapy was used as an adjunct treatment in addition to EMST and McNeil dysphagia therapy program. The most impressive gains in this case were cervical range of motion, most significantly in sustained neutral cervical posture, which was excellent because this is the swallowing posture. We can also appreciate gains in cervical extension with 42 degrees of improvement. The patient was able to continue working with improved speech intelligibility and returning to PO for pleasure. And here we can see a still on the modified barium swallow study. And then this is again the patient at the repeat MBS. You can see that head lift. And what we appreciate most is where the residue dwells. We can see prior to manual therapy, it was dwelling in the anterior portion of the pharynx, causing the aspiration. And when the patient was able to improve cervical posture, you can see the residue dwelling posteriorly in the pharynx. These changes were made over the course of 3 weeks with all hands on deck, including manual therapy, intensive bolus-driven therapy, and respiratory training therapies. This is the patient's best effort for cervical extension on day 1, and then this is again after 3 weeks. When we pull out of clinic and look at the data, we understand, as Dr. Hutcheson said earlier, radiation causes cellular change, as does surgery. We know that fibrosis can result from radiation. Again, about 50% of patients are experiencing at least a moderate grade of fibrosis. We know that fibrosis can lead to progressive decline in sensation and motor function over time. We appreciate the 3 pillars of exercise, our strength, endurance, and flexibility. And manual therapy can improve blood flow, oxygenation, lymph flow, circulation, and pliability, which can lead to improved sensation, range of motion, strength, endurance, and flexibility while decreasing pain. Changes associated with manual therapy are obvious in clinic, but supporting data are limited. And although we're starting to understand more in the way of safety and feasibility, we need more data to understand dose response and durability, the role of prehab, and the multitude of challenges that we face providing manual therapy. The use of manual therapy as a frontline or adjuvant treatment in head and neck and how it correlates with functional deficits and patient-reported outcomes has not been vigorously studied in this population. However, it's gaining popularity and interest. And when we turn our attention specifically to late effect dysphagia after radiotherapy, we see the investigation of manual therapy for fibrosis-related late effect dysphagia, or the Mantle Trial. This was an NCI-funded prospective single-arm pilot trial evaluating the feasibility and safety, as well as therapeutic potential of manual therapy. Disease-free survivors greater than 2 years after curative intent radiation for head and neck cancer with at least a moderate dysphagia and a moderate degree of fibrosis were eligible for this trial. Here we see the study schematic. So Mantle, the breakdown included the evaluation of cervical range of motion, modified barium swallow study, MRI, and various PROs. The patients completed 10 hours of sessions over the course of 6 weeks. This was on a titrated frequency over those 6 weeks. We repeated the evaluation following the in-clinic sessions. And then during the subsequent 6-week washout period, the patient independently implemented a clinician-prescribed home exercise program. And then we completed final post-washout evaluation. High adherence to both session attendance and home exercise completion, they were fantastic. It was a 92% completion rate, as well as a 60% reported adherence to at least half of the exercise program. So we were very pleased with these numbers. And in conclusion, from the Mantle Trial, we see that manual therapy is feasible and safe in long-term survivors. And the pilot data suggests that 6 weeks of manual therapy is associated with improved range of motion, both in cervical and oral opening, improvement in lymphedema and fibrosis, as well as symptom burden. The lack of significant swallow change may reflect the short duration, as we know that healthy muscles require more than 8 weeks to demonstrate measurable and functional change in strength and in change in muscle morphology. We also recognize the need to couple soft tissue mobilization with intensive functional swallowing tasks. The ideal dosing and durability of MT are uncertain, but we're exploring some of these questions in secondary analysis. Exploratory MRI and EMG analysis are planned to examine soft tissue and neurogenic change, underlying better range of motion and symptoms following manual therapy. And with that, I will stop sharing my screen and turn it back over. Thank you guys so much for allowing us to speak today.
Thank you. This is Audrey, and we do have a question actually from Miriam T, and it's directed actually to Carly. She states, although it would vary according to size and location of tumors and extent of surgery, how do you know when to start exercises for rehabilitation in regards to tongue mobility?
Yeah, that's a good question. So I think overall, we're trying to, and I'm sure you already know this, but emphasizing exercising during always. And so exercising and having patients swallow their own saliva. We wait for clearance for resumption of diet for surgical healing. But specifically around 4 to 6 weeks after surgery, we do kind of a new baseline, a new post-surgical baseline for patients in order to establish their function before adjuvant radiotherapy. And then that way we can kind of get an idea of their function for rehabilitation planning purposes. And then specifically in the study that I was discussing earlier, we start specific tongue movement rehabilitation where I was talking about targeted training at about 4 weeks after radiation. And mainly that's because we have to insert a device into the oral cavity that we're using for biofeedback. So that's why we wait a little while to have their dental stones made and things like that. But I don't, as long as there's surgical clearance, I really would emphasize the sooner the better.
Yeah, I would love to add on to that, I do think that while waiting, certainly for these more advanced sort of biofeedback device facilitated exercises until the adjuvant therapy is complete makes so much sense from a resource standpoint. From a rehab standpoint, absolutely, as was alluded, integrating just basic range of motion exercise, particularly in these patients who've had smaller glossectomies without any reconstruction, so primary closure. As soon as they're cleared for oral intake, most of the time the surgical team will clear them for some basic range of motion exercise. And that early mobilization is something that we absolutely advocate for. So it's just like anything where there's kind of a stepwise progression in our rehab. It's not all exercise or no exercise. It's like, what can they do at each step of the journey? And even in that early post-operative period, we're often advocating for basic mobilization exercise.
Thank you very much, ladies. We do have another question from the panel. Are there, as we know, there's many patients that do not have teeth. And so are there any studies that you include with patients with dentures?
I'm not sure. Particularly, I think that I would need a little bit more detail to understand exactly what types of studies are being asked about, like if that was pertaining to Dr. Barbone's presentation with the biofeedback mouthpiece and whether that can be integrated into the denture plate. Certainly for most of our pragmatic studies in swallowing therapy, whether it's proactive swallowing trials or, for instance, the Mantle late effect trial that we ran, we would include patients regardless of their dental status in our dysphagia management paradigms and try to scale those therapies to fit the individual patient regardless of whether they have teeth or not, knowing that absolutely a number of our patients may have extractions or some dental challenges, if you will. Carly, do you guys on the biofeedback, are you able to fit the palate in a patient who's completely edentulous?
So we have not had anyone who is completely edentulous as part of the study. We're working on different palate designs right now to include that, but right now we don't have anything to report on for that.
Thank you. The other question that is in regards to the carotid risks when we were talking about fibrosis of the neck, and what specific carotid risks do you screen for, and do you send people at certain times prior to starting therapies?
Yes, excellent question. In terms of manual therapy, everybody for the Mantle Trial was cleared by their cardiology team. For any type of myofascial release massage or lymphedema treatment, we are concerned with the degree of blockage in the carotids. We generally like to see less than 50%. The lower the number, obviously, the better. We really consider it higher risk once we get over that 50%. We're looking for clearance from the medical team. You're breaking anything off and causing more harm than good.
I will say that thanks, Holly, the other hot therapy that in our dysphagia management sort of toolkit that we often attend to the particularly carotid stenosis kind of issue that many of our patients with late effects are sort of battling in tandem to their dysphagia. The other therapy where we often will interface with our cardiology team or our medical team for clearance is expiratory muscle strength training, because the patient does generate so much expiratory pressure. It's essentially almost like a Valsalva of sorts during the task. It's certainly a therapy that's been studied even in the acute post-stroke environment. So it's not something that inherently has a cardiovascular risk associated with it, but we will check in a patient who has, bilateral carotid stenosis or more than 50% blockage just to make sure.
So we are, hi everyone, we're closing in on what we've surpassed our 1 o'clock stop time, and I want to be respectful of our clinicians' times and our panel. We are still taking questions, however, so if you wish to continue asking questions, you can do that. Or you can send them to the email that was on your invitation, and we will get answers for you and send them to you later. I also want to note that this webinar will be made available and sent around to all attendees after we're concluded. But if anybody has any final remarks, I want to thank all of our panelists, the team from MD Anderson for joining us today. Audrey, thank you so much for moderating and making introductions and doing Q&A. And if anyone has any questions, please contact Craig Smith. You will have received an invitation from him. But I want to thank everyone so much for being here. And I guess we will end today's second session right now. So thank you, everyone. Take care, and we will hopefully see you next week when we discuss a different topic. Thank you.